Hello friends, this is Dr. Sameen Afzal Junejo from Afzal Eye Clinic, Hyderabad, in Pakistan. Friends, today I will show you a video operated at my clinic last night. The patient is about 65 years of age and he had a right eye major cataract, and he also had a problem of enlarged benign hyperplasia of the prostate gland, and he is using TEM solution orally since a couple of years. And as we know already that TEM solution is alpha adrenergic blocker drug, and definitely it hinders the dilatation of the pupil. And usually the patients who are using TEM solution, they always face the problems of a small pupil, and there is a bit difficulty when we proceed for the phaco emulsification procedure in small pupil. But in this case, as per routine part of the phaco emulsification procedure, when I am doing the anterior capsulorhexis in a small pupil of not more than 4 to 4.5 millimeters, the rhexis is being guarded underneath the pupillary margin. Definitely it will not be more than 4 millimeters or 4.5 millimeters in diameters in a small pupil. And when we manipulate the iris during the capsulorhexis, the cystotomnodil, when it touches the iris anterior surface, there is an immense release of prostaglandin E2 from the iris stroma, which further causes the increased capillary permeability and decreased size of the pupil, even more smaller than the previous one. So the pupil is again becoming small and small as we are proceeding with the phaco emulsification. Thickness, full thickness corneal, two-step corneal incision is given with diamond keratome, and the diameter of diamond keratome is 2.75 millimeters. And in this case, a side port will be created at about 8 o'clock position with a 1.2 millimeter straight diamond keratome, and another side port at about 3 o'clock position to negate the astigmatism, aging astigmatism, or the astigmatism against the rule. Hydrodissection is being done. At all four quadrants underneath the pupil, and viscoelastic solution is injected inside in order to provide the lubrication. A phaco tip is introduced, and I will try my level best to keep the phaco tip all the time, all the way, exactly in the mid pupillary zone. The nucleus is engaged and splitted into two halves, keeping the phaco tip exactly in the middle compartment of the pupil in order to save the pupil capture, and with the help of a chopper the nucleus is broken into small pieces and taken up one by one. One should be very cautious to keep the phaco tip in the middle zone of the pupil. The small fragments of the nucleus are taken up under a high vacuum and low phaco power of not more than 60%, and in this case the vacuum setting is 550 millimeters of mercury. With 38 cc flow rate. After the whole nucleus is taken up, the phaco tip is removed. Still the pupil is small, and the remaining part of the nucleus, that is epinucleus and the cortical matter, will be aspirated with two-way irrigation and aspiration cannula. A two-way irrigation and aspiration cannula is a very balanced instrument in order to perform aspiration of the soft epinucleus and cortical matter. As you see in this video that we are aspirating the epinucleus and the cortical matter through extremely small pupil, keeping the important things in view that we should not go back deeper into the bag in order to avoid the posterior capsular rent, and the cortical matter which is caught at the 12 o'clock position will be removed through the side port in presence of a viscoelastic solution. The trapped cortical matter has been aspirated through side port. This is the significance of a side port. The side port is very instrumental in this stage. When the cortical matter is trapped around at 12 o'clock and it becomes very difficult to aspirate it through the main incision, viscoelastic solution is injected, and now a preloaded foldable one piece intraocular lens will be implanted exactly into the bag. A small pupil phaco surgery needs a lot of patience because we have to save the pupil capture and renting of the posterior capsule, so one should be very cautious about not injuring the inside structures of the eye. The oral prostaglandin, the prostate treatment in the form of alpha adrenergic blocking agent temsulon or temsulosine always creates problems. It does not allow the pupil to dilate and one has to use the iris dilating hooks and the iris dilating rings, but I do not use such things because there are many hazards of the iris hooks. Once the iris is manually stretched during the process of phacoemulsification, postoperatively it does not come back to its normal position, remains dilated or semi-dilated throughout life, and patient suffers from photophobia, flashes of light, and many complications of semi-dilated pupil, particularly during driving at night. Whenever the patient has got astigmatism against the rule, we should go for the formation of two side ports, one at 3 o'clock and at the other at the 8 o'clock position, in order to neutralize the astigmatism against the rule. The intraocular lens is being implanted in presence of a viscoelastic solution, OVD dispersive. Exactly into the bag. As we see that we don't have to do any extra efforts to position the IOL into the bag. And now, with the help of a Simcoe cannula, OVD dispersive is being removed completely from the anterior compartment of the implanted lens and the posterior as well. Because the persisting viscoelastic solution can give rise to postoperative cell reaction, mild uveitis, and refractive surprise in the form of induced myopia for a couple of days and transient rise of intraocular pressure. And now the injection, cocktail injection comprising of antibiotic, steroid and few drops of pilocarpine are injected intracamerally. Thank you very much, my dear friends. If you like this video, please subscribe my channel and also like it and press the bell icon so that you can receive future videos within a very short period for your guidance and better knowledge to achieve how to do the phaco emulsification in a small pupil. Thank you very much.